Jay won't let a camera beat him.
Yeah, you're good.
Okay.
It only records for so long.
A trick that sometimes we've used in the ED is using topical nitro. I really don't recommend you do that in the back of your rig.
Dilate him out.
Huh?
To dilate it out.
Yeah, yeah. The reactive hyperemia is a trick that I actually used in the helicopter a couple of times, and it works. What you do is you pump up the blood pressure until you don't hear the systolic anymore, and then you gradually release it until you start to hear the systolic, and then you leave the pressure right there. And then you go in and try and see if you can find the vein and get in. And I've had luck with it a couple times, you know, so that's... ECG difficulties, especially in the obese female, because you've got so much
Jeff
tissue.
Hoopman, you have a call on 613. Jeff Hoopman, 613.
It's hard to measure those electromagnetic waves through that much dense tissue. It's difficult to get the amplitude and the voltage that you need to be able to get a consistent, good EKG on these folks. A lot of times they're going to have flat or inverted T waves, and that's going to be normal for them. It's not going to be indicative of any cardiac myopathy or any damage. It's just going to be a normal finding for the obese patient. They're going to have more left ventricular hypertrophy. They're going to have more left atrial abnormality because these guys are, usually they've got some pulmonary hypertension, and that leads to a lot of left heart problems. Again, the T wave flattening, and sometimes they'll have that prolonged QT interval as well. So when you're assessing them, listening to lung sounds, try and keep the patient on the side or as upright as you can to listen to heart sounds and lung sounds. Something about being on the side displaces that tissue enough where you can get a better listen to it. Assess them for cyanosis inside the lips and the eyelids, because sometimes it'll be hard to assess cap refill, cyanotic states in the morbidly obese patient. To listen to the heart tones, put them on their left side. It shifts the heart closer to the chest wall where you can, get a better listen to it. Use the thigh cuff on the arm. Use the forearm if as a last resort. If you can't, got to do what you got to do. Try not to place electrodes on the abdomens. We've all done it, especially in the wintertime. You don't want to take their pants off or roll their legs up and get under their socks and stuff to do it on the limbs like you're supposed to, so we put them on the belly. In the obese patient, you're not going to get a good tracing when you do that, so try to stay away from that. Prices for equipment, and this is an old slide. I'm sure this is increased dramatically. Bariatrics is huge business right now, and the equipment is not cheap. So more of the challenges that we face, besides safely transporting and moving these patients, is increased workers' comp costs. 50% of workers' compensation costs in EMS were related to transferring and handling obese patients. 50%. Yep.
AMR did a study, their company-wide, and it was 31% of their BWC claims were from bariatric patients, even though they have specialized equipment and measures for handling it. You're still, because they do all the really big.
Oh yeah, yeah.
That's big.
Send me if you've got a link to that study.
Yeah, I think I actually have the PowerPoint presentation.
Awesome. I'd love to see that. Yeah, and maybe steal something.
Yeah, there it is.
So. I still didn't sign anything. This is just going.
Disclaimer for Dixie, she did not mean the word steel. Steel like in iron, like a beam.
This is just for the O2 unit days, right?
Yes.
Okay, all right.
Got you covered, Dixie.
Okay. All right, so meeting the challenge, we need more training. Absolutely, we need more training. And I actually tried to work it out with Mike, to get the truck in and the dummy again, Dr. Gable, to do the training, hands-on training again, but, it fell through. Dr. Gable was excited to come back up here again, but I guess something happened with Mike's schedule and he just wanted the lectures. It's all right, you don't get to play with. Oh, what did we name that dummy? Tracy? Tracy! He fell on the bathroom floor. Oh gosh. So, definitely, we need more hands-on training. And that's one of the reasons I love getting this lecture out, especially when we do the hands-on with the bariatric drugs. Because it really is. Because even when we're doing the scenarios, I mean, we expect you to act like it's a real patient, but you do have the luxury of not doing anything stupid and being able to assess the situation, size it up, and figure out the best and safest way to do, you know. And we you know, you guys saw from the statistics, it's not getting better, it's continuing to get worse and worse, you know, so we've got to step up and be ready for it.
The thing is getting them to call when they're relatively stable to handle them. Makes it easier to handle because
Exactly.
it gives us more time to move them and we can practice more safe maneuvers to get them there. But if somebody's having crescent chest pain, you can see they're having a big one. I mean, you can look at somebody and know
Yeah.
that there's an urgency there, and
There is, there absolutely is, which
we
is.
don't want to get anybody injured, but
Mhm.
you want to get them to the hospital, so there's a tough line there.
It really is, and you got to go back to your training because, I mean, you can't help them if you can't help yourself. If you end up laid out from an injury from trying to urgently move this patient, you failed. You have to take care of yourself first and then the patient. I mean, yeah, I mean, sometimes situations are urgent and our adrenaline goes up and, you know, we're critically thinking, we're like, okay, we do this and this and this and this, and, you know, and you get into it, and if you haven't thoroughly thought it through and, you know, gotta take care of yourself.
There were some of us that went to a study at OSU, wasn't it it was for moving patients. It wasn't just obese, it was all kinds of.
Oh,
They had
yeah,
some,
yeah.
they had some cool stuff there.
Very cool.
I mean, beds that you would slide underneath and then inflate the whole thing and it'd bring them all the way up to.
Yeah, yeah, I've seen those. Those are really cool.
That's, my memory, sparked my memory because of that chair, or whatever that.
Yeah. One of the, I think one of the tricks that they've been playing with in the ER at Riverside is not putting the cart to the side by side carts, but putting it at the end, and then using the rollers to drag the patient up. It's a lot easier to drag that patient up from one stretcher to the other than it is to try and push and pull.
Yeah,
Yeah.
makes sense.
Mhm. Yeah. Obstacles to removal. You guys have all kinds of toys. You know, you've got to make a checklist and know what you have and size up the scene. And okay, what have we got that will fit this situation and help us move this patient safely? Non-mobile patients are really challenging, and oftentimes when you get to these morbidly obese patients, they've been enabled and they've lived in one room their entire lives, and they've gotten so big they can't get through the doorway anymore. They're a prisoner to one room. And it can be really challenging to get these folks out. You about near need a structural engineering degree. it's you know. I'm a firm believer in Google Images. I think pictures say things better than I ever could.
Hey Jane, do we have any kind of understanding with the crane people? I mean, I know they'll bring them on auto accidents and stuff, but if we had an 800-pounder, we can't use a ladder for that. It's not recommended.
No, we don't have a particular company, but I'm sure we'd be on the phone.
Columbus probably does.
Yeah.
Talking about the use of cranes.
Yeah.
Yeah, cranes, forklifts, yeah, I mean, you use what you got. I mean, I remember, one of the very first bariatric patients I ever took care of, very early in my nursing career, it was like 92, and it was in Hopkinsville, Kentucky, before Campbell. And his name was Tracy, and that's why I named the bariatric dummy Tracy. But I loved Tracy, he was so awesome. But he weighed over 600 pounds. And this was in 1992. Nobody knew what bariatric equipment was. You didn't have bariatric trucks, you didn't have bariatric stretchers, beds, cots, wheelchairs. You didn't have that stuff back in the early 90s. So when the squad would pick Tracy up, they would have